Wait a second, let me see, just let me see that we are live or not. Wait a second. Yeah guys, we are live now. So this is the continuing session of the blood pathology or the hematology. We have already started the systemic pathology, right? And we have already completed the blood vessels and its disorders. And second thing, we have completed the congenital heart diseases. We have discussed the malpositions. We have already discussed the shunts and obstructions. So we have completed first part of the heart or pathology of the heart or heart disorders, and now we are left with the few more topics, that is heart failure, IHD, ARF. So they will be completed, I think, tomorrow. We have already scheduled the session for tomorrow, so kindly set the reminder for the same, so that we can meet tomorrow, and we can complete the whole heart. And first of all, thank you so much for all the love that you have shown on the Pharmac Easy and on my Unacademy profile. So if you haven't seen it yet, then you can go to the Unacademy and you can search Shiv Virmani right away. You will be seeing my page, my sessions, my plus course, right? And if you want to attend the special class, then you have to use Virmani as the code. Special classes are free, but still you have to use this code. Right. So welcome back to Unacademy, the largest online learning and the teaching platform. What's up guys? I hope you all are fine, you all are doing good, you all are well, and you all are fighting for your goals. And let's just proceed. So here in this slide it is teaching you how to install the Unacademy app. So it's a free app and you can install it from App Store and the Play Store, and it's a free app. You don't have to pay a single penny for installing or downloading the app. And even if after downloading you can use it for free, you can attend the live special classes, and you can take a few online tests as well, right? So that's the real benefit of the Unacademy. You don't have to pay a single penny and you can get the benefit for free. And I would prefer you to buy the plus course if you want to get um, uh, the batch course or the structured schedule from the top level of educators that we have on Unacademy, and that are from the esteemed universities like AIMS, Safdarjung, and all the best universities, and they are having experience of many years. So that's the main key. And yeah, so if you want to buy the plus course, then you can um, buy it for, so basically you have many choices. You can buy it for 5 months and you can test. You can buy it for 1 month, 3 month, right? And you can buy it for 1 month for testing purpose and use the code Virmani and you will be getting 10% off. And what all are the benefits of plus? So if you buy plus, then you can access the live classes, you can attend you can take the quizzes, right? And you can enroll yourself into the batch courses, right? You get the structured schedule, and that's the main strategy you get from the top level of educators. So if you are getting a structured schedule, it means that you are getting the strategy to crack a exam, and that's what is needed to crack any entrance exam. Then iconic course. So if you are a first, second, and or a third year medical student, then I would refer iconic. I would prefer iconic for you guys, because iconic के अंदर you get access to the plus, or you can access whole Unacademy, plus you can access whole prep ladder as well. So you get pre-recorded video lectures of the top level of educators there at prep ladder. Then you get the Q Bank 2.0. Then you can look into the rapid revision course as well, and you get the handwritten notes. So that's the best part, and that's the best course for a first, second, or a third year medical student, right? And if you come to the iconic, then you have only 4 choices. You can buy it for 12 months, you can buy it for 18 months, you can buy it for 24 months and 36 months. And code is same, Virmani, बट प्लस कोर्स में आपको काफ़ी ज़्यादा चॉइसेस मिलती हैं. यू कैन बाई इट फॉर 1 month, 3 months, 6 months, 12 months, 18 months, 24 months and 36 months. So many choices, and code is same. And welcome to the PathoNION, the pathology series, and we will be completing whole pathology in this series. And yeah, let's just get started with our slides. So guys, in our last class of systemic, in our last class of hematology, we have studied whole process of hematopoiesis. We have studied the bone marrow examination techniques. We have studied the anemias, first of all classification of anemias, then hypochromic anemia, then sideroblastic anemia. Then we have studied the thalassemia and megaloblastic anemias, and pernicious anemia. Then we started the bleeding disorders, and हमने काफ़ी सारे डिफरेंट डिसऑर्डर्स के बारे में डिस्कस करा था ब्लीडिंग डिसऑर्डर में. और हम कोगुलेशन डिसऑर्डर्स पर वी हैव लेफ्ट द कोगुलेशन डिसऑर्डर. सो we will be continuing with the coagulation disorders, and yeah, let's just jump to the slides. And I think this is the last sum up session, so kindly look into it. Yeah, so we have discussed hemophilia. Yeah, from DIC we have to start. So guys, DIC, disseminated, what's wrong with this pen, man? Yeah, disseminated intravascular coagulatory disorder. So DIC is the disseminated intravascular coagulation, and there is some error in the editing. Yes. So DIC is disseminated intravascular coagulation, and it is having many names. So guys, disseminated intravascular coagulation is also termed as defibrillation syndrome and consumption coagulopathy. So DIC is a defibrillation syndrome, and it is also called as consumption coagulopathy because all the platelets or the blood cells are consumed, and they are consumed for the formation of thrombosis, right? So all the cells ultimately they form a thrombus, or they increase the viscosity of the blood, and thus they increase the coagulation process, right? And that's why we call it as disseminated intravascular coagulation or consumption coagulopathy. without any external stress. Our body is coagulating its blood intravascularly itself, and it is a complex thrombohemorrhagic disorder. Intravascular coagulation is there and hemorrhage is also there, and that will cause secondary complications into some systemic diseases. So this can cause stroke, basically this can cause brain hemorrhage, right? And as your coagulatory pathway is increased or blood is viscous, so if the patient is having the coronary artery disease, then frequently patient will be having anginas, and anginas can develop into MI. So ये तो समझने वाली बात है, right? And because viscosity is increased and viscosity बढ़ गई, then these conditions predispose to the complications, the secondary complications. Then what is the etiology of the DIC? How our blood becomes this thick, or you can say how the blood itself can make the thrombus intravascularly without any external stress or without any external damage or any external tear. So first of all, massive tissue injury. So massive tissue injury के अंदर I am not talking about the road traffic accidents and all of that thing, right? All of that traumas. So I am talking, so here we have talked about in OBS syndromes, abruptio placenta, amniotic fluid embolism, retained dead fetus, massive trauma, metastatic malignancies and surgery. So abruptio placenta, amniotic fluid embolism, retained dead fetus, massive trauma, metastatic malignancies and surgery. And infections, especially endotoxemia, gram negative and meningococcal septicemias, certain viral infections, malaria, aspergillosis, then widespread endothelial damage in aortic aneurysm, hemolytic uremic syndrome, severe burns, acute glomerulonephritis, and miscellaneous are snake bites, shock, acute intravascular hemolysis, and heat stroke. So these are the etiologies of the DIC, right? So massive tissue injury in the OB syndromes like abruptio placenta. So abruptio placenta क्या condition होती है? Abruptio placenta is a cause of antepartum hemorrhage. First of all, this is the important thing from obstetrics itself. So it is the major cause of antepartum hemorrhage, right? And the second most important cause is placenta previa. So a placenta previa is the second most, or the one of the most common causes of antepartum hemorrhage, APH, right? So these are two different conditions. Abruptio placenta and placenta previa, they are two different conditions. First is abruptio placenta. So abruptio placenta, as the name suggests, abruptio placenta, as the name suggests, the placenta from its normal position, it is abrupted, and वो uterus में free हो चुकी है, and that is not a physiological process, that's a pathology. Then placenta previa. What is this placenta previa? Placenta previa is when the development of placenta is hampered or abnormal, right? So when the development of placenta is abnormal, means placenta has been developed abnormally or at a abnormal site. So as the name suggests, previa मतलब preview, right? Or you can see the placenta. So कहाँ हो सकता है? सो दिस इज अ यूट्रस एंड प्लेसेंटा कहाँ डेवलप हुई है? इधर. सो हेयर द प्लेसेंटा इज डेवलप्ड, right? So this is a placenta previa, and here blood will constantly ooze out, or constant bleeding can be there, and this is a common antepartum hemorrhage bleeding. एंटीपार्टम ब्लीडिंग और एंटीपार्टम हेमरेज का मतलब क्या होता है कि बिफोर पार्चुरेशन, before giving birth to the fetus, if there is a bleeding process. So you all know कि जब भी a female is pregnant, so she is having amenorrhea, right? That is, no menstrual bleeding will be there, right? But in this antepartum hemorrhage, there is a bleeding before parturition or before the expulsion of the fetus, right? And प्लेसेंटा प्रीविया के अंदर यहाँ पर प्लेसेंटा है. सो जब भी पेशेंट विल ट्राई टू स्टैंड अप, सो स्ट्रेस ज़्यादा लगेगा नीचे की तरफ बिकॉज ऑफ ग्रेविटी, एंड ब्लड विल कम आउट as a result of gravity or the stress, right, or the pressure. Then abruptio placenta. Abruptio placenta is the pathology when placenta is at its normal position and it is developed normally, but due to certain traumas, you can say, or certain abnormality, क्या होगा? So normal placenta develop हुआ है इधर, but due to certain traumas or certain abnormal contractions or any other etiology, because of any other etiology, this placenta will come out. And after the detachment of this placenta, so ये placenta में क्या fill होता है? Blood, एक तरीके से, right? It is having the huge arteries that basically supply the nutrient and the oxygen to the fetus, and that extract the waste products from the fetus. So when this placenta comes out, it will be causing bleeding, and thus as अभी तक parturition नहीं हुआ है, so यहाँ पर bleeding हो जाएगी, and these two are the most common causes of miscarriages, right? And the second thing is infections due to the, so ये वाला जो भी पार्ट अभी हमने पढ़ा, this is from OBS and gynae वाला पार्ट है, ठीक है, right? So ये सब पैथोलॉजी में इतना ज़्यादा इम्पॉर्टेंट नहीं है, but clinical point of view and gynecology point of view, it is very important, right? Then second, infections, especially endotoxemia and gram-negative and meningococcal septicemia, certain viral infections, viral infections, malaria, aspergillosis. So these can cause DIC. And third, widespread endothelial damage in the aortic aneurysm, hemolytic uremic syndrome, severe burns, acute glomerulonephritis. Then miscellaneous, snake bites, shock, acute intravascular hemolysis, and heat stroke, right? So these are the few etiologies of the TIC, right? I hope you all have understood the things. And what is the process or what is the pathogenesis of the DIC? So first of all, activation of the coagulation. So the etiology factors that we have discussed above, they initiate the widespread activation of the coagulation pathway by the release of the tissue factor, right? And then there is thrombotic phase. Then there is endothelial damage from various thrombogenic stimulus that cause generalized platelet aggregation and adhesion, right? So whenever there is intravascular damage or endothelial damage, then platelets will come. Platelets का तो काम ही यही है. So when there is a endothelial damage from various thrombogenic stimuli, this causes a generalized platelet aggregation and adhesion with resultant deposition of the small thrombi and emboli through the microvasculature. Then now comes the consumption phase. So as this thrombotic phase has been done, thrombus has been formed. Now जब भी प्लेटलेट और सेल्स आएंगे दे विल ट्राई टू एक्यूमुलेट हियर. एक्यूमुलेशन की वजह से ये बड़ा थ्रोम्बस होता जाएगा एंड ये स्प्रेड होता जाएगा एंड दस कम्स द कंजम्पशन फेज. द अर्ली थ्रोम्बोटिक फेज इज फॉलोड बाय द फेज ऑफ कंजम्पशन ऑफ द कोगुलेशन फैक्टर्स एंड द प्लेटलेट्स. राइट, जो भी कोगुलेटिंग क्लॉटिंग फैक्टर्स इधर आएंगे, प्लेटलेट्स आएंगी, ये यहाँ थ्रोम्बस में जाकर अटैच हो जाएंगी. Plus this thrombus will be containing RBCs and WBCs as well because ये भी साथ में ही आ रहे हैं, so they will be also consumed. Now secondary fibrinolysis as a protective mechanism, you all know after a clot is formed then our body tries to lyse that clot and क्या mechanism start होता है? Fibrinolysis, right? Fibrinolytic system is secondarily activated at a site of intravascular coagulation, and secondary fibrinolysis causes breakdown of the fibrin, resulting in the formation of FDPs in the circulation. So guys, as the protective mechanism, fibrinolysis takes place. Fibrinolytic system is secondarily activated at the site of intravascular coagulation. So the secondary fibrinolysis causes the breakdown of the fibrin and resulting into the formation of the FDPs in the circulation. Right. So let's see. So this is the pathophysiology. Right. So tissue injury हुआ, obstetrics complications हुए, malignant neoplasm, massive trauma, burns, surgeries. Then sepsis की वजह, sepsis is the another etiology, gram negative and other infections, right? Then endothelial injury हुई, aortic aneurysm हुआ, hemolytic uremic syndrome हुआ, severe burns, acute glomerular nephritis. This is the another etiology. Then these two etiologies will be causing tissue thromboplastin, or will be releasing or will be increasing the serum tissue thromboplastin. Then extrinsic coagulation pathway will takes place, और ये एक्टिवेट हुआ तो इंट्रावेस्कुलर कोगुलेशन तो स्टार्ट हो गई जो हमने अभी डिस्कस करी. देन व्हाट विल हैपन, प्लाज्मिन एक्टिवेशन हुआ और फिब्रिनोलिसिस स्टार्ट होगा. फिब्रिनोलिसिस स्टार्ट होगा तो एफडीपीज बनेंगे. एफडीपीज विल इनहिबिट द प्लेटलेट एग्रीगेशन, थ्रोम्बिन एंड फिब्रिन पॉलीमराइजेशन. सो दिस इज द नॉर्मल मैकेनिज्म, राइट? दिस इज द नॉर्मल मैकेनिज्म. एंड दस जब भी ये फिब्रिनोलिसिस होगा मतलब क्लॉट नहीं बन पा रहा, एंड इफ फिब्रिनोलिसिस एट इट्स पीक, देन इफ you have a bleeding, then your bleeding will be very high. So this is the secondary damage that it will cause, right? Now intravascular coagulation हुआ, उसकी वजह से all the clotting factors and the platelets are consumed, and thus अब अगर secondary bleeding कहीं हुई, secondary trauma कहीं हुआ, then you will not be having any clotting factors or any platelets to stop the bleeding and to make a clot, right? So that's why if secondary trauma हुआ तो there will be profuse bleeding. Now comes the endothelial injury. Endothelial injury हुई, then platelet aggregation होगा, so intrinsic coagulation pathway will take place. So जो भी बाहर से हो रहा था, extrinsic pathway will take place or will be activated. अंदर platelet aggregation होंगी endothelial injury की वजह से, intrinsic coagulation pathway will be aggravated or activated. Intrinsic coagulation pathway का भी सेम काम होगा, intravascular coagulation करेगा. Intravascular coagulation के बाद microvascular occlusion करेगा, and this microvascular occlusion will be causing ischemic tissue injury, right? So because there are many capillaries, right? Many capillaries जिनका lumen होता है बहुत ही छोटा होता है. So because of this platelet aggregation or because of the thrombus, अगर ये thrombus break down होके emboli form हो गया, then this emboli can um, occlude this thin lumen capillary, and thus it will cause a ischemic tissue injury, right? I hope it's clear. Then this microvascular occlusion will be also causing microangiopathic hemolytic anemia, right? Microangiopathic hemolytic anemia. So this is the uh, main pathogenesis of the DIC. So एंडोथेलियल डैमेज हुआ, बट बाहर से हमने कोई भी ट्रॉमा नहीं हुआ बिकॉज ऑफ द few etiologies or factors that will cause the endothelial damage. So after this endothelial damage, activation of coagulation pathway होगा, platelet aggregation start होगा, then this platelet aggregation start होने के बाद thrombus बनेगा, thrombotic phase के अंदर microthrombi will be circulated in the blood circulation, or because of the microthrombi are circulating, so all the clotting factors plus platelets, they will be consumed, and thus it will be causing a secondary fibrinolysis. So coagulation factor, platelets, ये सब decrease हो जाएंगे, and अगर secondary trauma होगा then there can be bleeding, plus FDPs भी present होंगे. Then clinical features. So two main features of DIC are bleeding, and the most common manifestation is the organ damage due to the ischemia caused by the intravascular thrombosis such as kidney and brain. So guys, पहली तो होगी bleeding because of the consumption of all the platelets and clotting factors. If the secondary trauma is there, then secondary trauma अगर हुआ तो क्या होगा? If there will be a secondary trauma तो profuse bleeding होगी, और इस profuse bleeding की वजह से there can be other complications, right? Then आप सबको पता है कि ये जो thrombus है, this is moving inside our blood vessels, right? So ये जो blood vessel में घूमे जा रहा है, ये कहीं ना कहीं जाके स्टॉप होगा. जहाँ पर भी ब्लड वेसल का ल्यूमेन छोटा है वहाँ जाके ये स्टॉप हो जाएगा, ऑक्लूड हो जाएगा, एंड इट विल बी ऑक्लूडिंग द ब्लड फ्लो. ब्लड फ्लो विल बी हैम्पर्ड, एंड जहाँ पर भी जिस कैपिलरी को भी ये ब्लॉक करेगा, दैट विल बी हैविंग इस्कीमिया एंड फर्दर organ damage. And most common organs affected are brain first of all, and kidney. And less common manifestations are microangiopathic hemolytic anemias, thrombosis in larger arteries and veins. Then laboratory findings. So guys, platelet count will be low, you all know, because all the platelets are consumed. Blood film shows the feature of the microangiopathic hemolytic anemia, and there is the presence of schistocytes, that is the fragmented red cells, due to the damage caused by the trapping and the passage through the fibrin thrombi. Then the prothrombin time and the thrombin time and activated partial thromboplastin time are all prolonged. Now comes the plasma fibrinogen levels. Plasma fibrinogen levels are reduced due to the consumption in the microvascular coagulation, and fibrin degradation products, that is FDPs, are raised due to the secondary fibrinolysis, right? And now comes, so ये I hope that ये सब समझ में आ गया होगा आप सबको, and अगर समझ में नहीं आया then you can ask in the chat. I'll be looking, I'll see कि कोई डाउट तो नहीं है. Let's see the chat. And एक बार आपका thumbs up मिल जाएगा, then we will be proceeding further and we will be doing the transfusion disorders, right? So I think that everything is going good. Let's just move further. Now comes the blood transfusion. So guys, ये इतना ज़्यादा important topic नहीं है, but this is clinically very important, and पहले रॉबिन्स में ये topic नहीं हुआ करता था, but now Robbins is having a separate section for the blood ट्रांसफ्यूजन. सो रॉबिन्स, जो नई रॉबिन्स आई है उसके अंदर एक नया सेक्शन डेवलप हो चुका है ब्लड ट्रांसफ्यूजन का. अर्लियर इट वाज नॉट देयर. सो ब्लड ट्रांसफ्यूजन के अंदर सबसे पहले तो ब्लड के हम जो ब्लड ग्रुप्स होते हैं, हम उसके अंदर सबसे वाइड स्प्रेड accepted blood group is ABO blood group system. So ABO blood group system is widespread accepted and we study this system only, and in our exams also ABO system ही पूछा जाता है. So guys, 4 तरीके के blood groups होते हैं, you all know AB, A, B and O, right? So the blood group AB will be having antigens AB on the red cells, right? एंटीजेंस होंगे ए बी, एंड जो ब्लड के अंदर सीरम एंटीबॉडीज होंगी वो कोई भी नहीं होंगी, बिकॉज ऑलरेडी ए बी एंटीजेंस प्रेजेंट है, तो उसके अगेंस्ट कोई और ब्लड ग्रुप नहीं दिखता, तो कोई भी एंटीबॉडीज नहीं होंगी एज सच इनिशियली. देन कम्स द ए ब्लड ग्रुप. सो ए कैसे पता चला? बिकॉज रेड सेल्स आर हैविंग ए एंटीजेंस ऑन देम. सो ए एंटीजन का अपोजिट इज बी. सो एंटीबॉडीज किसके खिलाफ होंगी? एंटी बी के. सो वी कैन नॉट ट्रांसफ्यूज अ बी ब्लड ग्रुप टू अ ए इंडिविजुअल, राइट? नाउ कम्स द बी. बी कैसे नाम पड़ा? बिकॉज इट इज हैविंग बी एंटीजन्स ऑन द रेड सेल्स. सो रेड सेल्स आर हैविंग बी एंटीजन्स ऑन इट्स सरफेस, राइट? सो 10 बी हो गया. व्हाट्स रॉन्ग विद दिस मैन? ये क्या हो गया? एंड बी का ऑपोजिट इज एंटी ए. सो वी कैन नॉट ट्रांसफ्यूज अ ए ब्लड ग्रुप टू अ बी इंडिविजुअल, राइट? इट्स नॉट पॉसिबल बिकॉज ऑलरेडी बी इंडिविजुअल के अंदर ही इज हैविंग नेचुरली अकरिंग एंटी ए एंटीबॉडीज इन द ब्लड. एंड नाउ कम्स द ओ. ओ के अंदर एंटीजेंस जो प्रेजेंट है वो ओ है. सो ओ के अगेंस्ट, मतलब ओ के अपोजिट क्या है? ए बी दोनों है. सो द सीरम of the patient will be having anti-A and anti-B, both antibodies. So in O we cannot transfuse any A or B blood group, but as such हम O को सब में ट्रांसफ्यूज कर सकते हैं A और B में, बिकॉज एज सच A और B और AB individuals does not contain any anti-O antibodies, right? anti-O नहीं होता. So O can donate the blood, but it cannot receive the blood. It cannot become recipient. O is always a donor. O cannot become a recipient, right? The rhesus blood group system, जिसकी वजह से हमें प्लस और पॉजिटिव और नेगेटिव का पता चला था. So पॉजिटिव और नेगेटिव का मतलब, सो इसने एक डी एंटीजन दिया अलग से. सो यू ऑल मस्ट हैव सीन कि आपका ब्लड ग्रुप इज बी पॉजिटिव और ओ पॉजिटिव और ए बी नेगेटिव. सो ये पॉजिटिव और नेगेटिव रेसस सिस्टम ने ही दिया, राइट? सो ब्लड ट्रांसफ्यूजन कैसे चलता है इसके बारे में थोड़ी सी बात कर लेते हैं. So blood transfusion goes through following sequential steps. First is healthy blood donor should be there. A blood donor should be healthy, without any infections, without any other abnormality, right? So there should be a healthy donor with the hemoglobin of more than 12.5 gram per deciliter, and he or she should be free of any infectious disease. Then blood collection. So blood collection is done by phlebotomy in the sterile plastic blood bag containing the anticoagulant, and most commonly used is trisodium citrate. So the mixing blood and the coagulant gently. So basically the blood and anticoagulant they mix, and right, so they just mix, or it makes the blood to stay in the liquid state for longer hours. Then the storage of the blood. So this blood bag is stored in the refrigerator at 2 degree to 6 degree Celsius. Then donor testing. So donor is test for the ABORH grouping and for the infectious organism HBV, HBS, AG, HCV, syphilis and malaria. Then blood grouping ABORH system of the recipient is obtained, and अगर वो compatible होता है, so like let's see if the donor is having A positive blood group, so इसके अंदर एंटीजेंस कौन से होंगे, एंटी बी होगा, राइट. और इसके अंदर हम नेगेटिव वाला नहीं डाल सकते बिकॉज ये इसके अंदर एंटी डी भी होगा, राइट, एंटी बी एंड एंटी डी. So we cannot provide the A positive individual to accept the blood from a B group, right, or a A negative group, right. So A positive should be given A positive blood group. So ये हो गया एक comparison, और we have come to a conclusion कि अब दोनों का ABORH testing or grouping is compatible. Then pre-transfusion compatibility testing of donor and the recipient. First is antibody screening of the patient serum to detect the presence of the clinically significant antibodies. Then cross-matching the patient serum against the donor red cells to confirm the donor recipient compatibility. So this is done in vitro. Then supervised blood transfusion is done to observe the reactions or the acute reactions, if any, because it can be fatal. The indications for the blood transfusion are acute blood loss, various hematological disorders, and in addition the whole blood transfusion आजकल नहीं होता. We can transfuse the components of the blood such as packed red cells, platelets, WBC concentrates, plasma components, fresh frozen plasma, cryoprecipitates, and plasmapheresis is also done to extract the antibodies from the blood, right. So when the patient is having autoimmune disorders, right, like myasthenia gravis and many autoimmune disorders, so we try to extract the antibodies or the autoantibodies that are automatically present in the blood. So we try to extract that, and वो extract हम कैसे कर सकते हैं, the process is called as plasmapheresis. Now complications of the blood transfusion. A carefully prepared and the supervised blood transfusion is quite safe. However, in 5 to 6% of the transfusions, untoward complications occur, and some of which are minor, while others are more serious and at times they are fatal. Transfusion reactions are generally classified into two types. First is immune and non-immune. So immunogenic transfusion reaction may be against the red blood cells, and there can be hemolytic reactions. Because they can be the causes can be due to the leukocytes, platelets and Igs. Non-immune transfusion reactions include the circulatory overload, massive transfusion, and transmission of an infectious agent, plus the iron overload when the patient is needing a constant blood transfusion, like in the thalassemias and all other disorders. So इसके अंदर काफ़ी ज़्यादा बार ब्लड ट्रांसफ्यूजन होता है विद इन अ वेरी लेस टाइम. सो iron overload is very common. So we try to give a binding agent or a chelating agent of iron, that is a desferoxamine, and if we are suspecting the iron overload, then desferoxamine is given. Then now immunogenic transfusion reactions. So immunogenic transfusion reactions, they are as under. Hemolytic transfusion reaction hota hai, right. So the red cells very rapidly they get destroyed, associated with the intravascular hemolysis due to the ABO incompatibility, since both the naturally occurring antibodies and anti-A and anti-B are capable of fixing complement. And the symptoms include the restlessness, anxiety, flushing, chest or lumbar pain, tachypnea, tachycardia, nausea, followed by shock and renal failure. Now comes the extravascular hemolysis. Extravascular hemolysis is more often due to the immune antibodies of the Rh system, and the clinical manifestations are relatively less severe and usually consist of the malaise and fever, but shock and the renal failure may occur rarely. Some patients develop delayed reactions in which the patient develop anemia due to the destruction of the red cells in the RE system or spleen about a week after transfusion. Such delayed reaction are generally the result of the previous transfusion or pregnancy. Then transfusion related acute lung injury. This is an uncommon reaction resulting from the transfusion of the donor plasma containing the high levels of the anti-HLA antibodies which bind to leukocyte of recipient, and these leukocytes then aggregate in the pulmonary micromutation and release the mediators of the increased vascular permeability, resulting in the acute pulmonary edema and the signs and the symptoms of the respiratory failure. अदर एलर्जिक रिएक्शन की अगर हम बात करें, बिसाइड्स हीमोलिटिक ट्रांसफ्यूजन रिएक्शन, अदर रिएक्शंस आर एज फॉलोज. फर्स्ट इज फेब्राइल रिएक्शन विच इज यूजुअली एट्रीब्यूटेड टू द इम्यूनोलॉजिकल रिएक्शन against the WBC platelets and IgA class immunoglobulins. The platelets with antibodies against IgA molecules sometimes develop anaphylactic shock on the transfusion of the blood from other human subjects. Allergic reactions such as urticaria may occur, and transfusion related graft versus host disease mediated by donor T lymphocytes may occur. Then non-immune transfusion, that first is circulatory overload. Circulatory overload result in the pulmonary congestion and acute heart failure, and it is the most important and the most common complication that may result in death following the transfusion, and the risk of the circulatory overload is particularly high in the patient with the chronic anemia, infants and elderly, and the onset may be immediate and may be delayed up to 24 hours. Then second is massive transfusion. When the volume of the stored blood transfused to the bleeding patients exceeds their normal blood volume, it results in dilutional thrombocytopenia and the dilution of coagulation factors. Transmission of the infection is there. Then many diseases that can be transmitted by the transfusion of an infected blood. These include hepatitis, HBV, HCV, CMV infection, syphilis, malaria, toxoplasmosis, infectious mononucleosis, brucellosis, AIDS, and the incidence increases in the patient who receive multiple transfusions, such as cases of hemophilia, thalassemia major, acute leukemia, acute severe hemorrhage, and it has therefore been mandatory that prior to any human transfusion, every unit of the blood must be screened for the serologic testing of HIV, HBV, HCV, and syphilis, and for the presence of the malarial parasite. Air embolism is unlikely to occur in the blood transfusion, and it is carried out with in which the blood transfusion is carried out with the plastic bags with a negative pressure as a usual practice nowadays. A debilitated patient may develop a symptomatic air embolism even if a small volume can make its way into the circulation, and whereas a healthy individual is at lesser risk. Now thrombophlebitis. So thrombophlebitis is the complication that is more commonly with the venesection for the blood transfusion, especially if it is done in the saphenous vein of the ankle rather than the veins of the arm, and the risk of developing the thrombophlebitis is further enhanced if the transfusion is continued longer than the 12 hours at a single site. Now the transfusion hemosiderosis. Post-transfusion iron overload with the deposition of the iron in the tissues of the body occurs after the repeated transfusions in the absence of any blood loss. Example, in thalassemia major and in severe chronic refractory anemias, the body has no other means of getting rid of extra iron except the iron secretion at the rate of 1 mg per day, and a unit of the whole blood 400 ml contains about 250 mg of iron, and after approximately 100 units the liver, myocardium and the endocrine glands are all damaged. Blood components. Blood from the donor is collected as whole blood in the suitable anticoagulant, and nowadays it is a common practice to divide whole blood into the components, which include packed RBCs, platelets, fresh frozen plasma and cryoprecipitate. The procedure consists of the initial centrifugation at low speed to separate whole blood into two parts, that is, a packed RBCs and the platelet-rich plasma. Subsequently, PRP, platelet-rich plasma, is centrifuged at the high speed to yield two parts, random donor platelets and fresh frozen plasma. Cryoprecipitates are obtained thawing of the FPP followed by transfusion or centrifugation, and apheresis is the technique of the direct collection of the large excess of the platelets from the single donor. So we have discussed the phenomena or the mechanisms how we can extract the whole blood, or we form the fresh frozen plasma or the cryoprecipitate, right? Then the applications of the blood component in the clinical use are as under. First is packed RBCs. These are used to raise the oxygen carrying capacity of the blood and are used in the normovolumic patients of the anemia without cardiac disease. 1 unit of the packed RBC may raise the hemoglobin by 1 gram per deciliter. Second, platelets. Transfusion of the platelet is done in the patient of the thrombocytopenia who have hemorrhage. Optimally, platelet transfusion can be given to a patient with platelet count below 10,000 per μl, and each unit of the platelet can raise the platelet count by 5,000 to 10,000 μl. Then the fresh frozen plasma. Fresh frozen plasma contain the plasma proteins and the coagulation factors that include first of all albumin, protein C, protein S and antithrombin. And FPP's transfusion is indicated in the patients of coagulation failure and TTP, and each unit of FPP raises the coagulation factors by about 2%. Now comes that cryoprecipitate. Cryoprecipitate is the source of insoluble plasma proteins, fibrinogen, factor 7, factor 8, von Willebrand factor, and indications for transfusion for cryoprecipitate are the patients require fibrinogen, factor 8, von Willebrand factor. Transfusion of single unit of the cryoprecipitate yields to about 80 IU or international units of factor 8. So the patients of hemophilia A or the classical hemophilia or von Willebrand deficiency वाले patients के अंदर we will be giving a cryoprecipitate, right? Or we can give fresh frozen plasma as well. Now comes the hemolytic disease of newborn. Hemolytic disease of the newborn results from the passage of the IgG antibodies from the maternal circulation across the placenta into the circulation of the fetal red cells. Besides pregnancy, sensitization of the mother may result from previous abortion and previous blood transfusions. Hemolytic disease of newborn can occur from incompatibility of ABO or RH blood group system, and ABO incompatibility is much more common, but the HDN in such cases is usually mild, while RHD incompatibility results in more severe form of the HDN. Then the pathogenesis. So HDN is due to the RHD incompatibility, which occurs when a RH negative mother is sensitized to a RH positive blood or RH positive fetus. So this results most often when a RH positive fetus, by passage of the RH positive red cells across to the placenta into the circulation of a RH negative mother. Normally during pregnancy very few fetal red cell cross the placenta, but hemorrhage during parturition causes the significant sensitization of the mother, and this sensitization is more likely if the mother and the fetus are ABO compatible rather than ABO incompatible. But when there is a second pregnancy, then this sensitization plays a role and it try to damage the fetus of the second pregnancy. Sensitization, though approximately 95% cases of the RH HDN are due to the NTD, and some cases are due to the combination of the anti-D with other immune antibodies of the Rh system, such as anti-C, anti-E, and rarely anti-C alone. So it must be emphasized here that the risk of the sensitization of a Rh negative woman married to a Rh positive man is small in first pregnancy, but increases during the successive pregnancies if prophylactic anti-D immunoglobulin is not given within 72 hours after the first delivery. If both the parents are Rhd positive homozygous, all the newborn will be Rhd positive. And while if the father is Rhd positive, and there is a 50% of chance of producing, so if father is having heterozygous state genotype, so there is a 50% chance of producing a Rhd negative child. And HDN due to the ABO incompatibility about is only about 20% pregnancies, and naturally occurring anti-B and anti-D antibodies are usually IgM, so they do not cross the placenta, and thus it is very rare chance that ABO incompatibility की वजह से there is hemolytic disease of newborn can occur. Right, so IgG is the readily antibody that easily can cross the placenta. So ABO HDN occurs most frequently in the infant born to the group O mother who possess anti-N, anti-B IgG antibodies, and ABO HDN differs from the RHD HDN in that it occurs in the first pregnancy. Coombs test is generally negative, and it is less severe than the latter. Then the clinical features. So HDN due to the RHD incompatibility in its severest form may result in the intrauterine death from hydrops fetalis. Moderate disease produces a baby born with severe anemia and jaundice due to the unconjugated hyperbilirubinemia. When the level of unconjugated bilirubin exceeds 20 mg per deciliter, it may result in deposition of the bile pigment in the basal ganglia of the CNS called as Kernicterus and result in the permanent brain damage. Mild disease, however, can cause only severe anemia with or without jaundice. Then laboratory findings. The hematologic findings in the cord blood and the mother's blood are as under. Cord blood shows variable degree of anemia, reticulocytosis, elevated serum bilirubin, and a positive direct Coombs test if the cord blood is RHD positive. Then the mother's blood is RHD negative with a high plasma titer of anti-D. Course and prognosis. The course in the HDN may range from the death to the minimal hemolysis to the mental retardation, and the practice of administration of anti-Rh immunoglobulin to the mother before or after delivery has reduced the incidence of the IDN, that is hemolytic disease of the newborn, as well as it protects the mother before the baby's RBC sensitize the mother's blood. Exchange transfusion of the baby is done to remove the antibodies and remove the red cells susceptible to the hemolysis is also also to lower the bilirubin level, right? Then WBC disorders. So this is the main granulopoiesis series of granulopoiesis. So first is myeloblast. Myeloblast will be giving rise to promyelocyte, myelocyte, metamyelocyte, and band forms, and thus PMNs. Then this PMN will be further in the tissues. It will be converting to the pus cells, right? So when there is a acute infection और वो ठीक हो गई है, so हमें क्या दिखेंगे? हमें दिखेंगे pus cells, right? Because all the neutrophils, all the acute inflammatory cells have been changed or have been converted to the pus cells. Then this myeloblast will be giving rise to promonocyte, and this promonocyte will be converting to the monocyte, and this monocyte will be further converting to the macrophage, right? So myeloblast will be giving rise to the neutrophils and pus cells, and myeloblast will also give rise to a monocyte as well. Then lymphoid series के अंदर lymphoblast is converted to the pro lymphocyte, and this pro lymphocyte will be converted to the lymphocyte, right? And infectious mononucleosis, so this is also called as kissing disease, and this is a disorder of Epstein-Barr virus infection. So this is the disorder that arises from the Epstein-Barr virus infection. So infectious mononucleosis, or IM, or glandular fever, is a benign self-limiting lymphoproliferative disorder caused by Epstein-Barr virus, or EBV, that is one of the herpes virus. So infection may occur from the childhood to old age, but the classical acute infection is more common in the teenagers and the young adults. The infection is transmitted by person to person contact by kissing with the transfer of the virally contaminated saliva. Groups of the cases occur particularly in the young age, living together in the boarding schools, colleges, camps, and military institutions. Primary infection in the childhood is generally asymptomatic, while 50% of the adults develop clinical manifestations, and the condition is so common that by age of 40, most people have been infected and developed antibodies. It may be mentioned here that EBV is oncogenic as well as, and it is strongly implicated in the African Burkitt's lymphoma and nasopharyngeal carcinoma. Pathogenesis. Epstein-Barr virus is the that is the etiological agent for IM, and also called, or B lymphotrophic herpes virus. So it is also called as B lymphotrophic herpes virus. And the disease is characterized by fever, generalized lymphadenopathy, hepatosplenomegaly, sore throat, appearance in the blood of atypical mononucleosis cells, and the pathogenesis of these pathological features is there. So in the susceptible seronegative host who lacks the antibodies, the virus is contaminated in the saliva and invades and replicates within the epithelium of the salivary gland, and there they enter the B cells in the lymphoid tissue, which possess the receptors for EBV. So initially, after attaining the virus, so the virus will invade the salivary gland and it will get settled in the epithelium of the salivary gland, where it will replicate and will enter the B cells of the lymphoid tissue and possess receptors for Epstein-Barr virus. The infection spreads throughout the body via bloodstream or by infected B cells. Viremia and the death of the infected B cells cause an acute febrile illness and appearance of the specific humoral antibodies, which peak about 2 weeks after the infection and persist throughout life. The appearance of the antibodies marks the disappearance of virus from the blood. Then, though the viral agent has disappeared from the blood, then the Epstein-Barr virus infected B cell, they continue to be present in the circulation as a latent infection. Then this Epstein-Barr virus infected B cell undergo polyclonal activation and proliferation, and these cells perform two important roles, which are the characteristic diagnostic feature of the IM. First is they secrete the antibodies, and second they activate the CD8 plus T lymphocytes. So first they secrete antibodies, initially IgM, but later IgG, that will be appearing lifelong. So IgM antibody is the heterophile sheep antibody used for the diagnosis of IM, while IgG antibody persists for life and provides immunity against reinfection. Then they also activate the CD8 plus T lymphocytes, and this combination is also called a cytotoxic T cell and suppressor T cell. CD8 T cells bring about killing of the B cell and are pathognomonic atypical lymphocytes seen in the blood in IM. The proliferation of these cells is responsible for the generalized lymphadenopathy and hepatosplenomegaly. The sore throat in IM may be caused by either necrosis of the B cells or due to the viral replication within the salivary epithelial cells in the early stage. And so this is the main flow chart of the pathogenesis of the IM. So first of all, there will be intimate contact, then the virus will be acquired, and this virus will invade the salivary gland and it will get settled in the epithelium. So after after invading the epithelium, it will be going to the B cell. देन क्या होगा, जेनेटिक ससेप्टिबिलिटी जिन भी पेशेंट्स के अंदर होगी उसके अंदर नेजोफेरेंजियल कार्सिनोमा भी कॉज हो सकता है बिकॉज ऑफ द एप्स्टीन बार वायरस. देन ईबीवी की शेडिंग होगी. ईबीवी इन्फेक्ट करेगा बी सेल्स को, एंड मोनोक्लोनल प्रोलिफरेशन अगर होगी देन इट विल बी कॉजिंग बी सेल नॉन हॉजकिन्स लिम्फोमा, प्लस इट कैन ऑल्सो कॉज बर्किट्स लिम्फोमा. अगर पॉलीक्लोनल एक्टिवेशन होगी, जैसे अभी हमने ऊपर पढ़ा, इफ देयर इज अ पॉलीक्लोनल एक्टिवेशन देन दिस बी सेल प्रोलिफरेट and it will be activating the CD8 plus T cells, that is cytotoxic T lymphocyte, और ये करेंगे, so they will be producing the symptoms. Then the B cell proliferation will be secreting the antibodies, initially IgM, and after IgM, IgG, and IgG will be living in the body for whole life. So thus there will be increase in the polyclonal immunoglobulins, right? So this infectious mononucleosis, they are having the clinical features of basically symptoms जो कि होंगे lymphadenopathy, hepatitis, splenomegaly, splenitis, encephalitis, meningitis, pneumonitis and skin rash. And the incubation period of IM is 30 to 50 days in the young adults, while children have shorter incubation period, and a prodromal period of 3 to 5 days is followed by frank clinical features lasting for 1 to 3 weeks, and subsequently complete recovery occurs after 2 months. And the usual clinical features are as under. First is during the prodromal phase, first 3 to 5 days, the symptoms are mild such as malaise, myalgia, headache and fatigue. Second is frank clinical feature that will be occurring in the next 7 to 21 days, that will be commonly seen after so basically these are the symptoms जो कि commonly देखे जाते हैं. First is fever in the 90% of the individual, sore throat, bilateral cervical lymphadenopathy, and other features like splenomegaly, hepatomegaly, transient erythematous macropapillar rash on the trunk and the extremities, and periorbital edema and jaundice. So first of all, complications. Although most cases of IM run a self-limited course, complications may develop in some cases as under. First is neurologic manifestations in children. Second is splenic rupture due to splenitis. Upper airway obstruction due to the hypertrophied adenotonsillitis, autoimmune hemolytic anemia, cold antibody type, and bacterial superinfection. And rarely there can be myocarditis and hepatitis and pneumonia as well. Then the diagnosis of IM is made by characteristic hematological and serological finding. So a hematological finding will be having in so the TLC, total leukocyte count, will be raised, and there will be 10,000 to 20,000 during first to the third week after infection. Differential leukocyte count के अंदर absolute lymphocytosis will be there. The lymphocytosis is due to the rise in the normal as well as the atypical T lymphocytes जो कि हमने देखा था अभी, and there is relative neutropenia. First is atypical T, then atypical T cells, essential to the diagnosis. So these cells are essential to the diagnosis of IM, and is presence of at least 10 to 12% of the atypical T cells, that is a mononucleosis cell lying in the peripheral blood and thus it will be causing peripheral blood lymphocytosis. And the mononucleosis cells are variable in appearance and are classed as Downey type 1, 2 and 3, of which Downey type 1 are found most frequently. And these atypical T lymphocytes or the mononucleosis cells are usually of the size of large lymphocyte, 12 to 16 μm diameter, and the nucleus rather than the usual round configuration is oval, kidney shaped, slightly lobate due to the indentation of the nuclear membrane, and contains relatively fine chromatin without any nucleoli, suggesting an immature pattern but short of leukemic features. The cytoplasm is more abundant, basophilic and finely granular, and may contain vacuoles. The greatest number of atypical lymphocytes is found between 7th to 10th day of the illness, and these cells may persist in the blood for up to 2 months. CD4 plus and CD8 plus T cell counts. So there is reversal of the CD4 plus upon the CD8 plus cell ratio. There is marked decrease in CD4 plus T cells, and there is substantial rise in CD8 plus T cells, that is cytotoxic T cell. And platelets, there is generally thrombocytopenia in the first 4 weeks of illness. Then serological diagnosis. The second characteristic laboratory finding is the demonstration of the antibodies in the serum of the infected patient. Right. First of all, testing of the heterophile antibodies. Heterophile antibody test जिसके अंदर we do Paul Bunel test. Paul Bunel test is used for making the diagnosis of the IM. In this test, patient serum is absorbed with the guinea pig's kidney. Serum dilutions are prepared which are used for the agglutination of the red cells of sheep, horse or cow and are reported as the heterophile titer of the test serum. A high serum titer of 40 or more times is diagnostic for the acute IM infection in the symptomatic case in the first week. Heterophile antibodies peak during the third week in 80 to 90% of the cases. The test remains positive for about 3 months after the illness starts. So thus the test has to be repeatedly performed, and similar antibodies also produced in the patient that is suffering from serum sickness and has been distinguished by differential absorption studies. Then heterophile antibodies are not demonstrable in children under 5 years of age or in quite elderly. Currently, more sensitive and rapid kit based test for heterophile antibodies and monospot is also available, and that is used. Then EBV specific antibody test. Specific antibodies against the viral capsid and the nucleus of the EBV can be demonstrated in the patient who are negative for heterophile antibody test. Specific antibody against EBV capsid antigen show elevated titers in over 90% of the cases during acute infection. Then IgM class antibody appears early and is thus most useful for diagnosis of the acute infection. IgG class antibody appears later and persists throughout the life. Thus, it does not have any diagnostic value but is instead used for assessing the past exposure of EBV infection because it persists throughout the whole life. Antibodies against EBV nuclear antigen are detected 3 to 6 weeks after infection, and like IgG class antibodies, they persist throughout the life. Antibodies due to early antigens may be elevated but are less useful in making diagnosis of IM. However, titers of these antibodies remain elevated for 3 to 6 months and their levels are high in the cases of nasopharyngeal carcinoma and Burkitt's lymphoma. Then IgA antibodies to the EBV antigen are seen in the patients of nasopharyngeal carcinoma or those who are at high risk of developing the EBV induced cancer. So EBV antigen detection is done by PCR method, right? And liver function test. In addition, abnormalities of the liver function test are found in about 90% of the cases, and these include the elevated serum levels of transaminases and rise in the serum alkaline phosphatase and mild elevation of the serum bilirubin. Then leukemoid reaction. So this is the reaction जिसके अंदर कई बार it is misdiagnosed as CML, or sometimes a CML is misdiagnosed as a leukemoid reaction, but there are many differences and we will be studying all those, right? So wait a second. What's wrong with this? Yeah. So leukemoid reaction is defined as a reactive excessive leukocytosis. So this is a reactive excessive leukocytosis. So right, and in a PBF resembling that of the leukemia in the subject who doesn't have leukemia. In spite of a confusing blood picture, the clinical features of the leukemia such as splenomegaly, lymphadenopathy, hemorrhages are usually absent, and the features of underlying disorder causing the leukemoid reaction is generally obvious. So a leukemoid reaction may be myeloid or lymphoid, and former is much more common. Myeloid leukemioid reaction causes. Majority of the leukemioid reaction involve the granulocyte series, and it may occur in association with a wide variety of the diseases. These are as under. First is infections, staphylococcal pneumonia, disseminated TB, meningitis, diphtheria, sepsis, endocarditis, plague, infected abortion. So these are the various infective etiologies that can cause myeloid leukemioid reaction. So we will be studying myeloid and lymphoid, myeloid leukemioid reaction and lymphoid leukemioid reaction. So myeloid will be myeloid का मतलब, myeloid means that the leukemioid reaction is taking place in the myeloid series, and a lymphoid leukemioid reaction के अंदर क्या होगा, the main series that will be affected will be lymphoid, right, lymphoid series. So a lymphoid leukemioid reaction will be having a lymphoid series का right, lymphoid series prevalent दिखेगी, and a myeloid leukemioid reaction के अंदर myeloid series will be over proliferated. Then infectious etiologies done, then intoxications like eclampsia, mercury poisoning, severe burns. Then malignant diseases, multiple myeloma, myelofibrosis, Hodgkin's disease, bone metastasis. So these are the some malignant diseases that will be having myeloid leukemioid reaction. Then severe hemorrhages and severe hemolysis, right? So the proportion of the immature cells are mild to moderate, comprised to metamyelocyte, myelocyte, and the blast. Blast will be generally fewer than 5%. That is in the blood picture, so it will be having a somewhat picture of CML, or it will be suggestive of a CML. Infective cases may show toxic granulation and Dole bodies in the cytoplasm of the neutrophils. Neutrophil alkaline phosphate NAP score is a very, 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 very important score when you are distinguishing between the two, CML and leukemioid reaction. So it is a very, 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 very important distinguishing factor. So NAP score, or neutrophil alkaline phosphate score, in the cytoplasm of the mature neutrophil in the leukemioid reaction is characteristically high, and it is very useful to distinguish it from chronic myeloid leukemia and in the doubtful cases. Cytogenetic studies may be helpful in exceptional cases which reveal negative Philadelphia chromosome. So Philadelphia chromosome will be positive in CML, and BCR-ABL fusion gene will be also positive in CML, but these two cytogenetic study will be negative in myeloid leukemioid reaction at least, or lymphoid leukemioid reaction may be. Then additional features include anemia, normal to raised platelet count, myeloid hyperplasia of the marrow, and absence of the infiltration by immature cells in organs and the tissues, right? Then lymphoid leukemioid reaction. A lymphoid leukemioid reaction may be found in the following conditions. First is infections. Infectious mononucleosis, cytomegalovirus infection, pertussis, whooping cough, chickenpox, measles, infectious lymphocytosis, TB, and malignant diseases malignant diseases may rarely produce the lymphoid leukemioid reaction. And laboratory finding के अंदर क्या होगा, leukocytosis will be there, but leukocytosis will not exceed 1 lakh. But when a patient is having CML, the leukocytosis will exceed this range, and the leukocytes will be more than 1 lakh or more than 1.5 lakhs. And the differential white cell count reveals mostly mature lymphocytes, stimulating the blood picture found in the cases of CLL, right? Then the contrasting features of the leukemioid reaction and the chronic myeloid leukemia. First is leukemioid reaction. So TLC, total leukocyte count, will be from 25,000 to 1 lakh, but in CML more than 1 lakh or more than 1.5 lakh as well. DLC के अंदर डिफरेंशियल ल्यूकोसाइट काउंट के अंदर डोमिनेंट सेल्स सेल पीएमएन, इमेच्योर सेल प्रीडोमिनेंटली मेटामाइलोसाइट्स एंड माइलोसाइट्स एंड माइलोब्लास्ट एंड प्रोमाइलोसाइट्स. सो immature cells will be there, but mostly जो ब्लास्ट सेल्स हैं वो कम दिखेंगे. बट एयर CML के अंदर immature cells will be of all the stages and myeloblast and the promyelocyte will be more than 10%. And NAP score is elevated in the leukemoid reaction but it is reduced in the CML. And Philadelphia chromosome will be absent in the leukemoid reaction but it is positive in the CML. ABL and BCR fusion gene will be absent in the leukemoid reaction but it will be positive in the CML. And major etiologies will be of infection, intoxication, disseminated malignancies and severe hemorrhage. But CML के अंदर due to RNA virus, HTLV oncogenesis, genetic factors, radiations and certain drugs and chemicals. Additionally, hematological finding क्या होगी? First is anemia, and anemia will be anemia is the additional hematological finding of both leukemoid reaction and CML. Then normal to the raised platelet count, same. Myeloid hyperplasia in the bone marrow, and this is also the same finding of both leukemoid and CML. Then organ infiltration. Organ infiltration will be absent, but in CML it can be present. And in CML, the patient will be having massive splenomegaly, which is not the case of leukemoid reaction, right? And now comes the myeloid neoplasms. So WHO has classified the myeloid neoplasm, and सबसे ज़्यादा important is myeloproliferative disorders. So the invigilator or जब आपका वाइवा होगा, so he or she will ask that describe the myeloproliferative diseases. So or tell the diseases that comes under the myeloproliferative diseases. So this is the major viva question. So first is chronic myeloid leukemia. CML is a myeloproliferative disorder. Second is chronic neutrophilic leukemia, chronic eosinophilic leukemia, chronic idiopathic myelofibrosis, polycythemia vera, essential thrombocythemia, and chronic myeloproliferative disease. And so these are the 7 myeloproliferative disorders. First is chronic myeloid leukemia, chronic neutrophilic leukemia, chronic eosinophilic leukemia, chronic idiopathic myelofibrosis, polycythemia vera, essential thrombocythemia, and chronic myeloproliferative disorder. Then myelodysplastic or myeloproliferative diseases, chronic myelomonocytic leukemia, and myelodysplastic syndrome के अंदर, this is also the favorite question that invigilator will ask you in viva, or right, or external will ask you in the viva. So myelodysplastic syndrome, refractory anemia and refractory anemia with ring sideroblast, refractory cytopenia with multilineage dysplasia, and refractory cytopenia with multilineage dysplasia with ring sideroblast, and refractory anemia with excess blast, myelodysplastic syndrome that is unclassified, MDU, or MDS with isolated deleted 5q chromosome. So acute myeloid leukemia with recurrent genetic abnormalities, so AML with T821, Q22, Q22, and AML with inverse of 16, P13, 13.1 and Q22, or T16:16 and P13 and Q22, and acute promyelocytic leukemia, AML with the T911, P22, Q23, AML with T69 and P23 and Q34, AML with inverse 3, Q21 and Q26, and AML megakaryoblast, and AML with mutated NPM1, AML with mutated CEBPA, SEPA, and acute myeloid leukemia with the myelodysplasia related changes, then therapy related acute myeloid leukemia, alkylating agent related topoisomerase 2 inhibitor, and acute myeloid leukemia, not otherwise categorized. So AML, that is, so basically this is the main um, classification of the AML that you have to learn, right? So AML, that is minimally differentiated, M0 or MO, AML without maturation, M1, AML with maturation, M2, AML myelomonocytic leukemia, M4, acute monoblastic and monocytic leukemia, M5A and 5B, acute erythroid leukemia, M6, acute megakaryoblast leukemia, M7, acute basophilic leukemia, acute panmyelosis with myelofibrosis and myeloid sarcoma, and myeloid proliferation related to Down syndrome, transient abnormal myelopoiesis, myeloid leukemia associated with Down syndrome, blastic plasmacytoid dendritic cell neoplasm, and acute biphenotypic leukemia, right? So these are the, how to end this. Yeah, so मेन जो 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 चीज़ें इम्पोर्टेंट हैं वो मैं बता देता हूँ. फर्स्ट इज़ यू हैव टू learn the myeloproliferative disorders, then you have to learn the myelodysplastic syndrome, then you have to learn this classification of AML, and बस ये three things are important. And ये जो AML वाली है, this we will be discussing in detail, right? So myeloproliferative, myelodysplastic and AML की classification, that is from M0 to M7, right? So we will be studying these things. So the myeloproliferative disorders are the group of neoplastic proliferation of the multipotent hematopoietic stem cells beside their common stem cell origin. These disorders are closely related and occasionally leading to evolution of the one entity into another during the course of the disease. Now comes the CML. So we have discussed a differential diagnosis, that is leukemoid reaction, and उसके अंदर काफ़ी ज़्यादा हमने डिस्कस करा एंड डिफरेंस डिस्कस करे, एंड डिफरेंस काफ़ी ज़्यादा है AML, CML एंड leukemoid reaction के. एंड नाउ इज़ द टाइम टू डिस्कस द CML और chronic myeloid leukemia. Chronic myeloid leukemia, right? So guys, CML is established by the identification of the clone of the hematopoietic stem cell that possesses the balanced reciprocal translocation between the chromosome 9 and 22, forming the Philadelphia chromosome. So the key or the keyword here is the reciprocal translocation. Reciprocal translocation. So you will remember the reciprocal, you will remember the translocation, but reciprocal आप भूल जाओगे, and that's what is the problem. So reciprocal translocation, right? So this is the keyword जो आप सबको you have to remember it every time. And reciprocal translocation of chromosome 9 and 22, that will be forming the Philadelphia chromosome, right? Philadelphia chromosome. And why the colors are so bright? Why the colors are so bright? So here we cannot choose our choice of color. So the T, this is also very dark. This is a very dark color. We should, yeah, back with the pen. So guys, the most important thing is reciprocal translocation. Reciprocal translocation. and reciprocal translocation of chromosome 9 and 22, that will be arising Philadelphia chromosome, and that will be forming the Philadelphia chromosome. The T922 involves the fusion of the BCR and ABL. So BCR is the breakpoint cluster region gene on the chromosome 22q11 with ABL, Abelson murine leukemia virus gene, located on the chromosome 9q34. So इनका फ्यूजन होगा एंड फिलाडेल्फिया क्रोमोसोम प्रोड्यूस होगा. सो इनका फ्यूजन होगा एंड रेसिप्रोकल ट्रांसलोकेशन होगा. सो 9:22 विद Q3411 BCR ABL जीन का फ्यूजन होगा विच शुड बी पॉजिटिव इन द मेकिंग the diagnosis of the CML. So these two things are very important in the CML, right? CML. Then the underlying pathophysiologic mechanism of the human CML is based on the observation that BCR and APL fusion product proteins are capable of transforming hematopoietic progenitor cells in vitro and form malignant clone. BCR-ABL fusion product bring about following functional changes. ABL protein is activated to function as a tyrosine kinase enzyme that in turn activates other kinases which inhibits the apoptosis. Then ability of the ABL to act as DNA binding protein is altered, and binding of the ABL to act in microfilaments of the cytoskeleton is increased. Then exact mechanism of the progression of the CML to the blastic phase is unclear, but following mechanism may be involved. First is structural alteration in tumor suppressor P53 gene. Second is structural alteration in tumor suppressor RB gene. Third is alteration in the RAS oncogene. Fourth is alteration in the MYC oncogene. Fifth is release of the cytokinin ILIB. And sixth is functional inactivation of the tumor suppressor protein phosphatase 8-2. Then clinical features. Chronic myeloid leukemia comprises about 20% of all the leukemias, and its peak incidence is seen in the third and the fourth decades of the life. A distinctive variant of the CML is seen in the children called as juvenile CML. Both the sexes are affected equally, and the onset of the CML is generally insidious. Some of the common presenting manifestations are as under. First is features of the anemia such as weakness, pallor, dyspnea and tachycardia. Second is symptoms due to the hypermetabolism such as weight loss, lassitude, anorexia and night sweats. Third is splenomegaly, and splenomegaly is almost always present and is frequently massive, and in some patients it may be associated with acute pain due to the splenic infarction. Then fourth is bleeding tendency such as easy bruising, epistaxis, menorrhagia and hematomas may also occur. Fifth is less common features include the gout, visual disturbance, neurological manifestations and priapism. Sixth is juvenile CML, and it is more often associated with the lymph node enlargement than splenomegaly. And other features are frequent infections, hemorrhagic manifestations and the facial rash. So guys, these all are the clinical features of CML. So CML के सबसे पहले feature is due to anemia, and this is also common with the leukemoid reaction. And सबसे पहले होगी weakness, pallor, dyspnea and tachycardia. Then symptoms due to the hypermetabolism such as weight loss, lassitude, anorexia and night sweats. Splenomegaly is almost always present and is frequently massive. Right, and this is not a feature of leukemoid reaction. So leukemoid reaction में कोई भी massive splenomegaly नहीं दिखेगी, and there can be acute pain due to the splenic infarction. Then bleeding tendencies such as easy bruising, epistaxis, menorrhagia, hematoma, they may also occur. So fifth is less common features such as gout, visual disturbance, neurological manifestation and priapism, they may also appear. Then juvenile CML. Juvenile CML is also often associated with the lymph node enlargement, lymphadenopathy and the splenomegaly, and other features are frequent infections, hemorrhagic manifestations and facial rash. Right. So now let's see the blood picture. So सबसे पहले anemia will be there, but anemia will be of normocytic and normochromic morphology. Right. and WBC will be there, but there will be marked leukocytosis, very much increase in the WBC. Then the natural history of the CML consists of the three phases, and these are very important three phases. First is so these are very important phases, और सब start करते हैं. So chronic phase होता है. First is chronic phase, then blastic phase, and then the accelerated phase. Wait a second. Chronic phase, accelerated phase, and the blastic phase. So guys, इन तीनों की भी blood picture is different, and सबसे ज़्यादा difference होता है basophil में. So let's see. Chronic phase of the CML begins as myeloproliferative disorder and consists of the excessive proliferation of the myeloid cells of the intermediate grade, that is myelocyte and metamyelocyte, and mature segmented neutrophils will also be there. Myeloblasts usually do not exceed 10% of the cells in the peripheral blood and the bone marrow. An increase in the proportion of the basophil is there up to 10%, and this is the characteristic feature of the chronic CML. And a rising basophilia is indicative of impending blastic transformation. So अब धीरे धीरे basophils बढ़ेंगे. So an accelerated phase of CML is also described, in which there is progressively rising leukocytosis associated with thrombocytosis or thrombocytopenia and splenomegaly. Accelerated phase has increasing degree of anemia, blast count in blood and marrow between 10 to 20%, and marrow basophils 20% or more, and platelet count falling to 1 lakh. Then blastic phase or blast crisis in CML fulfills the definition of the acute leukemia in the having blood or the marrow blast more than 20%. These blast cell may be myeloid, lymphoid, erythroid, or undifferentiated, and are established by morphology, cytochemistry, immunophenotyping. Myeloid blast crisis in the CML is more common and resembles AML. However, unlike AML, all rods are not seen in the myeloblast of the CML in the blast crisis. So guys, first is chronic phase, पढ़ लिया, accelerated and blastic phase. So these are the three phases of the CML. Then platelet count may be normal, but it is raised in about half of the cases. Then bone marrow examination. So examination of the marrow aspiration yield to the following result. First is cellularity. So generally there is a hypercellular marrow, right? But there can be replacement of the fat spaces by the proliferating myeloid cells. So then second is myeloid cells. Myeloid cells predominate in the bone marrow with the increased myeloid erythroid ratio, right? Because myeloid वाले बढ़ जाएंगे. And the differential count of the myeloid cell in the marrow shows similar finding as seen in the peripheral blood with predominance of the myelocytes. Then erythropoiesis. Erythropoiesis is normoblastic, but there is reduction in the erythropoietic cells. Megakaryocytes are conspicuous but are usually smaller in size than normal. Cytogenetic study on the blood will show the positive Philadelphia chromosome and the reciprocal translocation, and the BCR-ABL gene will also be positive. Cytochemistry में जो NAP है that will be reduced, and in the leukemoid reaction this NAP score will be raised, right? And other investigation are there. First is elevated serum B12 and vitamin B12 binding capacity, and then there will be hyperuricemia that will be arising the gout, right? And generally the prognosis is not so good because it is a leukemia. And let's see, insight into the molecular mechanism of CML has brought about the major changes in the therapy. First of all, the approach of the modern therapy in CML is targeted at the removal of all the malignant clones of the cell bearing BCR-ABL fusion protein, so that patient reverts back to the prolonged non-clonal hematopoiesis, that is molecular remission from disease, and this is achievable by the following approaches. Then imatinib oral therapy. The basic principle underlying the imatinib oral treatment is to competitively inhibit the ATP binding site of the ABL kinase, which in turn inhibit the signal transduction BCR-ABL fusion protein, and imatinib induces the apoptosis in the BCR-ABL positive cells and thus eliminates them. Imatinib is found more effectively in the newly diagnosed cases of CML. Complete hematologic remission is achieved for 18 months in 97% of the cases treated with imatinib. Allogenic bone marrow. Allogenic bone marrow transplantation. Although the treatment modality offers the proven cure, and it is complicated with the graft versus host disease, and therefore post-transplant immunosuppressive treatment has to be continued. Otherwise, this can become fatal as well. Interferon A. Prior to the imatinib, the allogenic transplantation chronic phase of CML is used to be treated with the interferon A, and this is the drug of choice. Then chemotherapy. Chemotherapeutic agents are used in the treatment of CML for lowering the total population of the WBC, and these include busulfan and cyclophosphamide and hydroxyurea. Others besides above and other forms of the treatment include the splenic irradiation, splenectomy and leukapheresis, because there can be massive splenomegaly और उसकी वजह से काफ़ी ज़्यादा symptoms produce होते हैं, तो patients can forced to do splenectomy, and the most common cause of death in 80% of the cases in CML is disease acceleration and blastic transformation. Right, now we will be continuing further in the next session, and yeah, bye guys, take care, stay healthy, stay safe, stay positive, and thank you for being here, thank you for attending this session, thank you for coming. Now I have to go, and we'll be meeting soon, we'll be meeting tomorrow, and we'll be continuing the heart, the systemic pathology, and साथ साथ हम इसकी भी sum up session start रखेंगे ही. And yeah, bye guys, take care, stay healthy, stay safe, stay positive, and yeah, don't forget to follow me on Unacademy app as